Hey, good afternoon, everyone. Okay, I've learned from my friends in Africa, this is not how you start a session. Good afternoon, everyone. Love it, that's much, much better. It's day two. And you know, as we've been planning this meeting for over a year, this morning I had to pinch myself and say, it is day two of the meeting. Everybody's here and the sun is shining. So we're gonna fix all that ails you, and likely in this session, so I'm glad you're here. We are going to have a terrific panel and really shifting gears in this meeting from measurement, which is hugely important. And we spent a lot of time getting it right because, you know, you've heard garbage in, garbage out. And we really value few meaningful measures. And what do they look like? How can they be adapted to different settings? However, the thing that I think that we are often challenged with as academics is measurement for what? Right? What are we trying to do with this measurement? Is it to publish beautiful papers, have wonderful technical discussions? I think for many of us in the health system space, the motivation truly is improvement. It's an applied science, as I've said from the beginning of this meeting. And so for us, really shifting into the improvement side is vitally important. So I just want to start the session by reflecting a little bit on some surprise findings, to me anyway, from the Lancet Global Health Commission on High Quality Health Systems. When we convened that commission back in 2016, 2017, you know, we want to take a fresh look at quality. We spent a lot of time on measurement. You've heard about some of those advances and other advances in this meeting so far. But there was a section of the report that the Lancet wanted us to write, which was about what do we do to improve? And to do that section, we needed to delve into a whole new literature, new to some of us, because we hadn't, you know, I was much more working on kind of the health economics, health system organization, and measurement side of the equation. But then we looked at the improvement science, what's called improvement science. And here I have to say, so we deployed a wonderful team of researchers. We had commissioners from all over the world. We brought together systematic reviews on many of the improvement strategies being tried and tested throughout the world, and particularly in lower and middle income settings. Because I would argue that wherever, of all the places you look, the place you can least afford to give poor care is in low income settings, which neither have the resources, right? Nor the health capital that is available in high income countries for small errors. Really, any small error makes a huge difference to people's lives. So what did we find? We were shocked. We found two major things. One is that improvement science is not so scientific. So we found a lot of studies in what goes under the various term of quality improvement, improvement science, that were quite small, quite local, very focused on clinics, clinicians, and healthcare teams. Very few studies in lower income countries. But furthermore, what we found was that from the studies that were done and were of good quality, the effect sizes on actual quality of care for users were extremely small. And not only were they small, we saw almost no replication of those methods into a scaled up system. So methods like PDSA cycles and, you know, guidelines and reminders and short-term trainings, which were one of the most popular one-week trainings, two-week refreshers, seem to make very little difference. And this is not the moment for me to regale you with all of the literature on that. Please have a look at our report and much of the work that has happened since. But what that did show our commission is that micro-level improvements, the improvements that are being made at the clinic, provider level, it's about staffing. Is it about just equipment? Is it about reminders? Is it about short-term refreshers? Those things do not make a meaningful difference at the system level. They do not improve outcomes at the population level. They may for a short time in those clinics. Difficult and expensive to scale and extremely difficult to sustain. Okay, so what do we do? I remember a meeting in Johannesburg with the commission, with the Department of Health in South Africa, where we sat and debated and thought hard about what's going on. And actually during that meeting is when the Better Birth trial results came out. And those of you who follow this field know that that trial, which was immaculately done, a wonderful cluster randomized study of clinic level improvement for childbirth, I found a null result in a study that was extremely well-powered to detect even the smallest result for mothers and newborns surviving. So simply trying to improve things clinic by clinic will not elevate health systems to better performance. And that's not just a finding in low-income countries, I will say. Many QI improvements also have very small effect sizes globally. Okay, so this is not to dismiss all of it. It's just that when we're looking at the missed opportunities to save lives in lower income countries, we need a much more effective set of tools. And so this panel will help us think about what those tools are. What are the structural changes, the foundational changes in health systems that are going to be required to make a difference? How do we change, for example, governance and policy and financing and care models, the way we deliver care and organize care? Instead of organizing it thinking that we will have highly competent clinicians, we may have to organize it differently, actually, right? We may need to involve communities and others to come into this picture. So I am delighted to introduce our august panel, who will share from their research and their experience some of the structural levers for improvement and engage with us all in discussion. So I'll call you up and please come on up. I want to start by introducing Dr. Elvin Geng, Director of the Center for Dissemination and Implementation and Professor of Medicine at the WashU School of Medicine, who focuses on behavioral interventions and implementation science to improve health system performance. Next, Dr. Mark Huffman, co-director of the Global Health Center and the William Bowen Endowed Professor of Medicine at WashU. Dr. Huffman specializes in cardiovascular disease prevention and health system improvement. I rarely hear about a cardiologist talking about prevention, so I'm so excited. Dr. Xiaohui, I'm a former family physician, so all I did was prevention. Dr. Xiaohui Wang is associate professor and chair of the Department of Social Medicine and Health Management at Lanzhou University School of Public Health, and a leading researcher on provider performance, health workforce training, and system integration in China. And next up, Ms. Tracey McNeill. Ms. McNeill is Director of Primary Healthcare at the Bill and Melinda Gates Foundation, where she oversees global strategies to strengthen primary care systems, and particularly an expert in data-driven approaches, which are so timely right now. And last but not least, Dr. Jose Figueroa. He's Associate Professor of Health Policy and Management at my old employer, Harvard T.H. Chan School of Public Health. Dr. Figueroa's work examines health system financing, payment reform, and cross-country approaches to quality improvement. And so what I've asked is each of our panelists to make about 5 to 7 minute remarks. They are permitted to use slides, and we're going to ask our colleagues in the back to help us bring those up if they're required. But I think otherwise we're ready to roll. So over to you. Let's do it in the order that you've all received. Is that okay? Mark Huffman first? Okay. Oh, Elvin first. Oh, in the order you're sitting. I'm good with that too. No problem. So let's go ahead with Dr. Geng, who will talk to us about behavioral. Oh, yeah. I mean, we have so many orders, really. We have one on paper, one in reality. We can roll with it. So please go ahead.
And if you can pull up my slides just as I get started. So I'm a practicing preventive cardiologist, but also interested in these larger scale issues where heart disease causes 1 out of every 3 deaths around the world. I mean, let that sink in. 1 out of every 3 deaths around the world is due to something that is entirely preventable or postponable. Yes, we will all die at some point. And to have the opportunity, so to speak, to die from cardiovascular diseases is such that you've outlived other risks. And nevertheless, health systems are just not generally prepared for the silver tsunami, as it was described earlier. So I've had the really great fortune to work with Dr. DK Oji, who's here in the audience today, for the past 8 years, working to integrate cardiovascular services into routine primary care in Nigeria. Dr. Lisa Hirschhorn, who's also here, is a key member of this study as well, known as the Hypertension Treatment in Nigeria program. And when we first started working in the Federal Capital Territory, some of the stakeholders said, "Are you here to come collect data?" And DK said, no, we're here to help strengthen the system. And by building that as our core ideal for what we're here to do is to strengthen what's already there, then we were welcomed in. Now, we have kind of a foundation in dissemination implementation science, which really tries to think about multi-level thinking of strategies to implement evidence-based practices. Now, there's certainly healthy behaviors that relate importantly to blood pressure. So blood pressure, as I say to my patients, there's a trait, state, error model. So trait's your usual blood pressure. The state are the conditions which the blood pressure is measured. So we do have a measurement issue with blood pressure that's different than, say, cholesterol. And then error, we're constantly using upper arm cuffs to measure central aortic pressure. It's imperfect, but we tolerate some of this noise. And so those health behaviors are important, but at the same time, medicines are the core of how blood pressure is treated and controlled. And that's what I do in my clinical practice here in St. Louis, and that's generally what's done throughout the world. But most people around the world are not treated. Most people around the world do not have their blood pressure under control, including in the United States. So we have a problem with our entire approach, including the medicines that we use. Most people need 3 medicines to get their blood pressure under control. And so delivering that in a more efficient way is something that I've been very interested in through combination therapy. But structurally, when I try to prescribe that to my patients here in St. Louis, they go to the pharmacy, we don't have it. Or the co-pays a lot more. Ooh, is that really necessary? So trying to think multi-level, like how are we going to strengthen a system that wasn't necessarily designed initially for the treatment, diagnosis, treatment, and control of cardiovascular conditions such as raised blood pressure. So we've conducted a quasi-experimental study using an interrupted time series across 60 public primary care facilities in the Federal Capital Territory of Nigeria. This figure shows time on the x-axis and proportion control on the y-axis. We started out at 22% control and ended up at 56% control, greater than 50% control for more than about 18 months. And this demonstrated that it is not only feasible, but this was more than 21,000 patients, more than 140,000 clinic visits, 2/3 of the participants of whom were female. It's possible to implement this at, I think, a moderate scale. And we did this through a variety of strategies that's based upon the WHO's HEARTS technical package. In this, we think about things at the policy level, like what are the guidelines, what are the standard treatment protocol, how do we strengthen healthcare worker performance, those sorts of things. But we didn't just start this in a vacuum, and we certainly thought about this from an asset-based approach. There are many strengths in Nigeria for the delivery of cardiovascular care. So the first is that the government, the Federal Ministry of Health, created a document, the National Multi-Sectoral Action Plan for the Prevention and Control of Non-Communicable Diseases in 2019. This put this at the headline of, we want to improve hypertension control and see if we can achieve greater than 50% throughout the country. The second, DK and others, including through the WHO Nigeria office and Resolve to Save Lives, helped to create a simplified treatment protocol, which this has been demonstrated to be a strategy to simplify and improve the quality of care for people with hypertension in many systematic reviews. And you see this guideline or this protocol, it's in one direction. There's not a lot of arrows going in that confuses practitioners. This was modeled after Kaiser Permanente, Northern California's successful experience where they improved hypertension treatment or control from about 45% to greater than 80%. Next is this national guideline, also sort of institutionalizing this as something important on the federal level. But on the right is really this policy on task shifting and task sharing. So a really core strength in Nigeria is that community health extension workers are a professionalized cadre of health workers. These are people who are paid and they go to technical school, they're respected in their communities, and they're stable in their jobs. So on the measurement front, we actually measured health worker job stability, and there was only about 15% turnover of community health extension workers over a 4-year period. That's remarkable. That means that initial training and subsequent supportive supervision that we provide is more likely to be retained, and the system is likely to be able to absorb new skills and capacity. That's different than in other parts of Africa and other parts of the world where scope of practice laws limit what community health extension workers can do, or community health workers. So it's at the beginning of our study, we did formative research asking community health workers, you're busy, is this something that's acceptable or appropriate for you to do? And they said, absolutely, because so many of our patients come in with high blood pressure and don't tell anybody, we treat them. We're not supposed to, and we're worried if we're gonna get in some legal trouble, but maybe you can help us. So we negotiated a deal where essentially this was allowed under research purposes, and based upon the research that we provided, this was now a policy that was raised up nationally that now allows the prescription of blood pressure-lowering medicines by community health extension workers under the supervision of a physician according to the National Treatment Guidelines and the Standard Treatment Protocol. So really thinking about the assets and strengths has been important for us. Another key aspect that I imagine is part of a lot of the work that you do, and is certainly central to what we've been trying to do, is to strengthen the people within the system, including some of the scientists and workers here. So on the left is Nana Ripier. She's a community medicine physician who studied normalization and sustainability. And Dr. Ripier has demonstrated that this program has been normalized, sort of integrated into routine care, and that the conditions for sustainability are high when we ask not only frontline health workers, but also health managers about this. This is a priority, not just within the Federal Capital Territory, but beyond throughout nationally in Nigeria. Dr. Gabriel Shedjul is the head of the Department of Family Medicine at the University of Abuja Teaching Hospital, who's studied the implementation of supportive supervision with mentorship from Dr. Lisa Hirschhorn. And so every quarter for 3 years, the supportive supervision visits occurred 93% of the time. So that fidelity to the strategy, I think, was very important and is not included in the HEARTS technical package, and yet we think that that's essential. That's one of the key ingredients that we were able to bring to the field. The next two ladies, Drs. Grace Shedjul and Eugenia Uguneji, they helped implement a drug revolving fund for blood pressure lowering medications. This is a concept that's been used in other conditions in Nigeria, but hadn't been yet adapted for cardiovascular conditions. Again, we think a financing strategy has been lacking in HEARTS, and yet is absolutely necessary to reduce the out-of-pocket costs for blood pressure lowering medications. So we think this was an additional advance that we've provided to help think about how things are going to be paid for, these medicines. Lastly, Dr. Tunde Ojo is a psychiatric health worker who helped raise awareness about the hypertension treatment in Nigeria program and hosted more than 300 community meetings over a 3-year period with more than 6,000 participants. So really getting the word out, creating demand for the services that were available in public primary care. So in 2.0, we're doing national scale-up with funding from the National Heart, Lung, and Blood Institute. Dr. Oji is the contact PI for this. And we're scaling up throughout Nigeria's 5 other geopolitical zones. We're looking at sustainment of hypertensive service integration in the Federal Capital Territory using the DIHS2 program. And we're also integrating diabetes in the Federal Capital Territory. So we're really excited for the next wave of this program, and we're also starting to collect data for multinational scale-up of this with the hope of trying to really integrate cardiovascular service delivery in primary care, because if it's not going to be integrated there, this problem of people dying from cardiovascular disease is only going to worsen over time. Thank you very much.
Wonderful, thank you. I wish we could just leave that map as like the North Star of this whole meeting. Look at it's a huge country, right? The idea of scale up at this level, it's just incredible. Okay, next up is Xiaohui Wang on provider training challenges. Oh, by the way, I did encourage all our panelists to share successes and failures. I think we can sometimes learn just as much from failure, thank you, as from success.
Thank you, Margaret. Good afternoon, everyone. I'm very delighted to be here to join the panel to share our experience in China. How did we try to improve the competency of primary healthcare workers? Before that, I'm going to share with you some very brief background in China. Actually, in recent years, as you might know, China has made a large investment to strengthen our primary health care system and also to solve the shortage of the health primary care workers. I did a research and we invested what? In 2011, we have a project named the Rural Oriented Free Tuition Medical Education Program. And in this program, we try to enroll the students from the high school and to do the undergraduate education in the medical school for 5 years. And the tuition fee is totally free. It sounds wonderful. And after the 5 years education, you have to go to the hospital to do some like the training. The clinical practice training is for 3 years. And then after this 3 years, you have to go to the primary healthcare institutions. It's your duty to do so, and you cannot refuse to do so. After these 11 years, then you can be a doctor, but you still need to work in a very rural area and the primary healthcare levels. But the figure shows that in this year, we altogether actually have enrolled over 90,000. Oh, sorry. Over 90,000 of students was enrolled in this program. And after that, they graduate, they do the practice in a very community level. Actually, about only 70% stayed in the community level hospitals. It's another story. It's a number of the health professionals. And to improve the competency of the professionals, in 2018, we have a PhD professional training project. We invested about 2 million and to train 700 and more than 700,000 PhD workers, include about the 500,000 community, the village doctors. That's the investment. And after this large investment, actually evidence shows that the quality of care is still very low, remains poor. And maybe you can see from this figure as a picture, if you can see it clearly, our team, we did a USP project which used the unannounced standardized patient to evaluate the quality of primary health care. And we found that you can see the history taking and the testing and the treatment are all below the average. You can see I just take the hypertension and the diabetes as an example. The average is already very low, but these two conditions, the quality is still below the average. So this evidence makes us thinking about it. What should we do, and what can we do to close the gap? There's a gap in the quality, so we think it might be the good way to do something to bridge the competence gap. So we developed a smartphone-based app. It was a virtual patient. The virtual patient, we select 11 tracer conditions, and hypertension and diabetes were absolutely included. So we developed this app based on clinical practice guideline, and we think it's a very good way to both assess the competency of the primary healthcare workers and to use this as a training tool to increase the competency. So what we did the validation. And during the validation stage, the participant rate and the feedback are all good. But after validation, when we try to think about move forward, we think it's a scalable, low cost, and an innovation way to improve the competency, to increase the knowledge level, and to change the physician's behavior. So we go to the field, and we moved from a trained test to the real-world implementation. We are very excited about the first result, and we think it should be a good one. But according to the previous survey in China, we know that only 30% of the patients go to primary healthcare settings, and the quality rating is not actually good. It's like 20% said that the quality is good, but when we moved from this stage to the validation, to the reality, it showed that you can see the orange bar, the participant rate is actually very low, especially at the very beginning. When we tried to persuade the doctors to use this app, and they just told us, we are too busy, and we did not do that. We have to kind of like send a kind of reminder to them. Hi, here's a test you need to finish, and would you please do this? And when we think about this project, we think, oh, it's a project. I have the funding, and I will run this project. And the result is very good, and I think I will do this. And at the very beginning, the participant rate is lower than the validation stage. That's for first one. And then when we did the intervention, and we found that actually the treatment and the diagnosis accurate rate did not increase, not much, because according to the literature, there will be a 30 to 40% of the score increase after this kind of the AI-driven training, something like this. But we didn't see that at all. And it's very frustrating actually to us. Shall we move on to do the RCTs, or shall we just stop here? It's very it's expensive to do the RCT. So as a researcher, I think I would like to take a step back. And I stopped there, and I was like think about what happened, and if the tool is actually technically worked, why the doctors did not want to use this, and what's the problem? Is this problem due to the app is too complicated? I don't think so. So what worked? We went back and relied on the CIFR framework, the consolidated framework for implementation science. We want to explore what happened here. Actually, it was not in my plan at all. So I went to the field, and we did the in-depth interview among the stakeholders, like the leaders of the local health bureau and the director of the hospital, and also the physicians who's supposed to use it. And we shift our focus from the project or the tool itself to the context where we do this. Okay, and then we found out that actually there's a systematical problems. Maybe the leadership and the leadership engagement is low during the RCT very early stage, and also the policy integration is very low. And after that, I go to the Health Bureau, talked with the leader there, and they finally they approved. They would like to including this VP as a regular training program from the Provincial Health Talent Training Department. So I think it's a good thing. That's what when I looked ahead, we suggest a booster model to do this kind of competency improvement project. We actually found that it's it's not only the technical, but it's a system. We need to turn it around. Thank you.
Wonderful. Thank you so much, Okui, also for sharing what must have been an immensely frustrating project. So thank you for that. I know that we'll have lots of questions and discussion. Let's please move next to Tracey, who will talk to us about your experiences in management and data.
Is this on? Thank you. Yeah, thank you. I'm approaching this from a slightly different perspective. So obviously working for the foundation, we're funders, but also spent most of my 47-year career in healthcare doing delivery and operational delivery. So in the foundation, I've been able to bring those two things together, and I've spent many months and many visits out in the field looking at monitoring performance and how we can improve performance in primary healthcare, and working with Margaret and others and looking at how we can then improve quality outcomes for patients. So I think, and I'm going to give you 2 or 3 examples that have really struck me on my travels that really resonate. But before I do that, I think that some of my learnings and the learnings of the primary healthcare team in the foundation is that there is no single answer. We all know that primary healthcare is complex. Budgets vary. Often our work is around, I call it following the money, so seeing where the money flows within the system and making sure that it goes the last mile to deliver services that we really care about. What I see from many of my travels and working with the Foundation Exemplar team is that what plays a really important part, and I'm going to come on to give 2 or 3 examples of that, is around leadership and stakeholder engagement. So when you see leadership, and that can be at a district level, a county level, a federal level, a state level, when you see really strong leadership in primary healthcare, then you know that that makes a difference. And that's also been proven in the work through our Exemplar team. And so I was lucky enough to be in Nakuru in Kenya only 2 weeks ago. And I traveled 3.5, 4 hours very early in the morning and was with the Commissioner for Health, who is equivalent in a county level in Kenya to almost a health minister. And that person hadn't been in post that long, just over a year, I think, 18 months. And she was not from a health background, she was from a financial background. I asked her how many times she visited the facilities and went out to the field. And she said 2 or 3 times a week. And I was slightly surprised by that, because that's a lot for someone who's in a really high-profile senior role. And then she went on to tell me that all of those visits are unannounced. And so she either goes in the morning on her way to work or after lunch or whatever. And what I saw in Nakuru was really strong leadership, but her leadership was really making a difference. The team were motivated because she understood the problems. And sure, sometimes she went to facilities and the staff weren't there, and she made a few phone calls and they would suddenly appear, no surprise there. But however, she was hands-on, she was walking the talk, she understood the problems. She could then go back and actually make allocation, she could financing, she could make trade-offs, and she really fundamentally understood the problems. And there's many colleagues here in the room from Kenya, and there was an excellent session I attended earlier today. And it's hard in Kenya, it's not easy, but that's a good example of that kind of leadership. What I've also seen is that data drives performance. You need routine data. I'm not a fan of KPIs that are like 100 or 200 that you're monitoring, and you kind of get lost in the data on a page. So selecting the right performance indicators is critical. And so what you see on the slide here in front of you, and I just want you to really focus on the right-hand side, is we started working with Dr. Azra, who's one of the most influential, powerful health ministers I think I've met. And she's the Minister of Health in Sindh in Pakistan, an area in Pakistan that's really challenged by geography, and it's a real low resource setting. So what she has started doing through our partners and with support from the foundation is what we call regular routine monitoring of primary healthcare facilities, all of them. They're visited once a month by independent monitors. Many people say, oh, we can't afford to do that, it's very expensive. It's 0.05% of the overall healthcare budget. And at the moment, it's important that they're done by independent monitors. Those independent monitors, and I've had the privilege of going out with them, they go into facilities, they collect about maybe 50 different data points, but they're looking at the facility itself, is there running water, are labour rooms equipped, are staff turning up for work. They look at supply chain management, they do medicines audit, they're looking at security, they're looking at 24-hour services. All of that data goes up to a central level digitally. You don't need internet connection to actually collect the data. They can collect the data and then when the monitors get to a certain point, then they can upload the data to a central point. Once a month, the Minister of Health sits down with the district managers, and there's a dashboard which is traffic light color-coded. And you can see individual performance of each facility and by district. And I've seen the health minister make trade-offs in terms of, we need to allocate more money here because there isn't an electricity supply, or this is a really remote facility that actually that isn't properly staffed, so how do we rearrange rotas? And also the independent monitors may take photographs of photographic evidence, which is a real-time record. I can't show this slide. I'll come to the slide that's on the screen in a second. But when we first saw the first set of data, there was a facility, a remote facility that was reporting that they did 30 deliveries a month. When the independent monitor went there, took a photograph, it was a donkey stable. So that was quite difficult to deal with, but I'm making the point, asking you not to repeat that, but I'm making the point that actually when you start doing independent monitoring in real time and you collect data through digital systems, then you really get to know what's going on. But what I want to draw your attention to on the slide, just the data on the right-hand side, was that we were challenged that could we improve maternal mortality in Sindh. And then one of the issues was labour rooms were not available 24 hours a day. Those of us who've started our careers clinically know that babies aren't always born during the day, so the lack of facilities at night was a problem. And so in the space of just over 2 years, by independent monitoring, you can see that the functionality of labour rooms went up by 81 percentage points. So from 10% to 91% over 24 hours. Skilled birth attendance improved by over 60%. Home births reduced and institutional deliveries went up. And so that was a real success story driven by the Minister of Health, driven by data, and showing the art of what's possible. And that wasn't by increasing allocations, etc. It was about different use of resources and trade-offs. My final example is quickly I'll come to Rwanda. A lot of work we've been doing there on digitalization and AI through partners. And the Rwandan RSSB, the Social Security Scheme, wanted to move to a capitation fee. And so when I first started working in Rwanda in 2014, the health financing system was piles of paper. I'm not exaggerating, as high as this room. And it took 6 to 9 months for payments to go to the facilities, which meant poor care delivery, or one of the results was poor care delivery. But now the whole system has been completely digitalized using AI for some of the administrative tasks. And some of the early data that I saw a few weeks ago is around prescribing habits of individual physicians. And so some physicians, healthcare providers, are clearly prescribing 3 to 5 medications in a consultation, and others it's either 0 or 1 to 2. So huge variances in prescribing habits, inconsistent use of treatment protocols, quality regimes, etc., and ultimately poor quality for the patients. And so now with that level of data, then you can drill down and you can actually begin to look at improving quality, but also importantly, managing supply chain management. So my time is up, so I'm going to stop there. Thank you.
Wonderful. Thank you so much, Tracey. Wow. Love those rich examples, and so recent as well. Excellent. Let's move on to Dr. Geng. Elvin, tell us a little bit about the work you've been doing to do one of the hardest things in quality, actually, which is to change provider attitude.
Good afternoon. Glad to be here and great to be on this panel. I want to speak a little bit about work that I've had the privilege of being involved in with partners in Zambia, but also just to note that there are many, many threads that link our work here in St. Louis to that work as well, and it continues to be generative bidirectionally, and I think that's been a real pleasure to see. So let me frame maybe the issue that we are looking at in a way, and I've spoken about this a couple times in the last week, so I apologize if any of this is a rerun to anybody here. So implementation science is kind of about getting evidence-based interventions into use, right, into routine use. And there are many, many problems with that, as we've all heard, and there are many kind of proposed types of solutions. You know, you've heard about guidelines, incentives, you hear about coaching, this, and there are, you know, hundreds, maybe thousands of these kinds of things that we try to do to get evidence into practice. One way to organize all that is to imagine that the health system is composed of structures and agents. And structures are things like policies, rules, norms. It's also infrastructure, equipment, and things like that. And then within that, you have people, healthcare workers, who are agents, and they work within that system. And the structures shape the work that agents can do. There are certain things you cannot do if the structures say no. If the policy is nurses cannot prescribe, then you can't prescribe if you're a nurse. If they change the policy, then you can. At the same time, the agents in the system also reshape and restructure or reproduce the structures that exist as well, right? And many of these things are at the facility level. Many of them are above this facility level. But in any case, the people working in the system, you know, shape the norms. They shape the workflows, and they create or recreate the hundreds of thousands of things that happen in practice every day that you can't put into a protocol. Like, you can't write down everything that will happen in even one patient interaction, right? So I think in implementation science, sometimes we favor, or we imagine that we favor the former over the latter, right? We imagine we can sort of constrain and control our way out of the situation by making sure healthcare workers don't do, like, you know, unwarranted and unnecessary variation, which is true. There's no question that that all exists. But there are also ways in which we can think about how to make the most of the discretion, the adaptivity, the creativity of healthcare workers that we spend a lot of time investing in, training, by the way, to make sure that the elements of the of service delivery that can't be completely legislated are also optimized for people. So taking that as a broad framing, I think, to be specific, you know, a group of us, including Alok Modi here and others, my colleague Kombatende Sikombe gave a presentation from Zambia earlier this afternoon. But we've been interested in the question of the patient-provider interaction in retention in HIV care. And I think this actually has a lot of resonances outside of HIV care. So 30,000-foot backdrop, HIV treatment scales up around the world, starting from around 2005. Millions of people get on treatment. Very soon after 2010, 2012, people start to realize that a lot of people are not retained. And if you take a physician's or a public health practitioner's point of view, you say, like, well, why aren't people coming? This is going to save their lives, but they come and then they don't come. It's a sort of supply-centered perspective. So, you know, a lot of research was done by many, many groups. There are many reasons why people don't come, right? Transportation, their spouse got arrested, their kid needs school fees, there is, you know, people have to work, et cetera. They get scared, they have a fight at the clinic, it's too long. So there are a million reasons why people don't come. But we developed a hypothesis, which was basically that there are going to be structural problems with care. There are going to be psychological problems, stigma. But there is a lever in between all these things, which is the human factor, which is the interaction between healthcare workers and patients can either make all of those other problems worse, or it can make those problems better, right? And if we can shape the behavior of healthcare workers to resituate their work and align it with the kind of expectations and the hopes of people seeking healthcare, then maybe that's one mechanism of improvement. It's a lever. It doesn't solve the other problems, but it interacts with the other problems to make them better or worse. Okay, So I'll just be brief about the actual study and give us a chance to talk about lessons learned. And I always need the aid of timing to keep me from going on too long. But
1 minute.
is that right? All right. Well, okay, so then I won't have time to talk about all the implications. I'll just tell you about the study, and then in the subsequent discussion, we'll talk about like what worked and what didn't work and why. The bottom line is that through support from the Gates Foundation, our group did a research sort of program that lasted over 7 years, where we tried to design ways to meet providers where they are and enable them to bring out their latent or their not so latent impulses to do right by people, for people, in a way that is caring. And we tested this package of things that included measurement of patient experience essentially at scale. I mean, 170,000 individuals in a province in, over approximately 24 of the largest clinics. And the overall effect over the course of 2 years was that it improved patient experience as measured by people who were trained to evaluate and who the clinics were blinded to, and it improved retention. It did not improve our endpoint of viral load suppression, but it gave us encouragement and that the hypothesis has some legs. Let me just end by saying that the research program also helped us reconceptualize like what impact is, like what is the meaning of this kind of research, right? Because you're not going to take the exact program elements and replicate it at scale. But what you do reveal is that there is a sort of a set of mechanisms to create this kind of change, and it leads to change in the health system that in subsequent discussion I'll try to name, that ultimately has an impact. Carol Weiss talked about the use of research as creating a more enlightened policy environment. You can't draw the line from one research study to this, to that, to then impact at scale. But what you do is you put it into the environment, and hopefully the environment makes better decisions through a unpredictable, contested sort of way for something better to come out the other end. So let me perhaps stop there with my 1 minute.
Thank you so much, Elvin, and thank you. Yeah, a round of applause. And thank you for giving us that bigger frame and also a bit of a reframing of impact. We need to be a little bit maybe more realistic and humble about what research impact means. Over to you, Jose, please.
Good afternoon, everyone. My name is Jose Figueroa. I first want to apologize to people who are disappointed that I'm not Giuseppe Figueras. Similar names, but I am not as dynamic or as interesting as he is, so I apologize in advance. I did ask him last night if he wanted to give this panel because he could give this talk, and for continuity, he said two things. One, no, and two, that I need to work on my knowledge brokering. So I'm gonna try. So I wanted to chat about financial incentives in healthcare from an international perspective, and give you a sense of how we can learn from other countries when it comes to the designing and implementation of models of care that use incentives to try to either control healthcare costs or improve quality and outcomes. In my opinion, all countries are trying to figure out how to deal with rising healthcare costs with aging populations and how to improve quality of care and outcomes. And over the past 2 decades, many countries are investing in value-based payment. There are many words for this: pay for performance, financial incentives, value-based payment reforms. But I'll quickly give you a framework for how to think about it across these programs. And this is informed by some work in the US, but you can apply a similar framework in other countries. In my opinion, there are 4 key models or 4 key features of payment models. The first one are public reporting models, where you just ask healthcare facilities, hospitals, or providers, maybe primary care physicians, to report on quality measures. And it's just you report, and if you don't, you get penalized, period. It's just enforcing reporting. The second type of model we call pay for performance programs. And this is where you go a little bit further. Not only do you have to report, but we will penalize you or maybe bonus you depending on how well you do. So you reward the high performers and you penalize the poor ones. The third type of model are episode-based payment models or bundled payment models. And this is where you go even a little bit further, where you not only are required to report on quality measures, but you'll also be evaluated by how much spending or how much utilization for a particular type of person with a particular episode you have over a course of a specific time period, typically around 90 days, at least in the United States. And then the fourth one is where you go a little bit further. This is more population-based payment models. These are where you take a group of providers and you place risk for total healthcare costs and also make them responsible for the set of quality measures as well. In the United States, over the last 2 decades, we're trying to move away from the left to right. And many other countries are similarly experimenting with these models of care. Now, just to put it a little bit kind of simpler as well, as you go from left to right, you notice that you are bringing in more units of the healthcare system together. So for example, in public reporting or pay-for-performance models, you typically target one group of one entity in the healthcare system. For example, hospitals. You make hospitals report on quality measures, whether it be mortality or readmissions, and then if it's a pay-for-performance program, you evaluate them and penalize them or bonus them. In a bundled payment model, you extend maybe beyond the hospital, involve more units of care, including, for example, the post-acute care facility. In the US, it's often nursing homes that do this, or a home healthcare agency that might do physical therapy at home. And then in the population-based models, in the US, we call them accountable care organizations, is the dominant form of doing this, is you incentivize all units within the healthcare system, and again, place risk for total spending across a year typically for a group of people, and then again, they have to beat certain benchmarks in terms of quality benchmarks. Many countries are experimenting with these types of models, and I'll just say that the US is again experimenting across the board, and I would argue it's one of the leaders in experimentation at a national level with many of these forms. So now I'm going to give you just a couple of case studies to show what we could learn from other countries. So there's 2 key programs in the United States. Simplistically, because I don't have that much time, the first one is a readmissions program where hospitals are penalized if they have higher than expected readmissions for a certain set of conditions. The second one is another program called the Value-Based Purchasing Program, which incentivizes hospitals. Either you get a penalty or a bonus for a bunch of different measures, including the one that I'll show you is 30-day mortality for specific conditions. For example, like 30-day mortality when somebody's hospitalized with heart failure or a pneumonia or an acute myocardial infarction. Since I only got 5 to 6 minutes, I'll have to summarize by saying, in the US, 10 years of studies, they're not really working. So the question is, why did they fail? And what could we have learned from other countries even before the implementation of these programs? And one thing to say is, when we start with the readmissions reduction program, it was really to reduce utilization of hospitalizations, or fewer hospitalizations. And if you take a step back and would have asked, well, how are we at baseline in terms of the number of hospitalizations in our population, how well do we do relative to other countries? And the answer is, on average, we don't hospitalize as much as other countries. So you might expect that the program that tries to reduce utilization of hospitalizations might have very little room to improve if we compare ourselves to our neighbors. Now, if you hone in, that was total hospitalizations. What about, like, as an example, heart failure readmissions? This is a standardized persona that is part of our iconic collaborative that Irini presented earlier. The US, if you ask the question, how well do we do in terms of 30-day readmissions for heart failure patients, in this case also with diabetes, we're on the lower side as well. So again, we don't maybe have as much room for improvement. And so maybe this is a signal that we're reaching a ceiling effect as a country, if you look at how other countries are doing. Now, another way of looking at it, in some cases, when you wrote out these programs, they're national. All hospitals participated in the readmissions reduction program. And how do we assess whether or not the program worked? There's no counterfactual, there's no good control. So international comparisons allow you to maybe bring in a control. In this case, comparing ourselves to the US, comparing the US hospital performance on 30-day readmissions for heart failure with our friends in Canada, and we have very similar trends. So it's hard to see, but in the post-implementation period, the rate of readmission was slightly lower over time, but the slope matched the slope of Canadian hospitals, which were not affected by the program. Now, I'll give one more example, and then I'll stop. This is our two more examples. 30-day mortality rates, again, the US is not as bad on the low side. We're very similar to Germany and Australia, so we didn't see improvements on the second program I mentioned. It did not work on improving 30-day mortality. What about episode-based population models? Just two more examples, or one more example here combined. I don't have that much time. I'll say they worked. But in reality, you have to look at the details. Karen joined Maddox, who's here, she's doing this. So maybe you'll say they worked a little bit. She's a nation's leader on this. She's also my mentor. How are you? And then she'll even say that's not enough. You have to, so it depends on the context. There's a lot of details, but they worked a little bit. And where we see the evidence working is that they reduce spending and utilization in the post-acute care setting, meaning people spend fewer days in rehab settings. Now, what could we have learned from an international comparison before we had implemented this program? You would have seen that the US is an outlier when it comes to utilization of post-acute care rehab facilities. So this is an example of where there is an area where we are probably in need of doing better or doing less, and a program that is incentivized to reduce this is more likely to have worked for this metric. All right, I'm going to stop there.
Wonderful, thank you. I mean, don't you wish all academic papers came with like a big stamp saying it worked? It didn't work. And a small side comment, you may call Canadians our friends, but I assure you my Canadian family reminds me all the time that the inverse is not in fact true at this moment. We are nice, but this has exceeded our bounds. All right, this was an incredible set of presentations, and you can see the range of efforts and approaches to improve these complex entities that we call health systems. What I would love to do, and I am conscious of time, and I'm conscious of the fact that on the other end of this session are cocktails, not just a regular get-together, but cocktails and blues that you're going to hear more about. So we're going to keep this quite brief. What I am hearing about from most of you, all of you really, is that the complexity in the health system in some ways has to be reflected in the approaches that we take. The idea of coming in with a silver bullet was never going to work, but there is a belief system. You know, these financing models that Jose you're talking about, they've been tried elsewhere. They've been silver bullets all over the place that have missed the target, and yet we keep replicating. And I think from each of you, I'm hearing it's not going to be this one thing, right? And yet, I think the other problem that we face in the improvement world when we say that, and we certainly faced this in the commission when we said, well, it's not going to be one thing. You can just give up on that right now. What we get is an incredibly frustrated response from the policymakers who say, I can only do one or two things. There's only so much policy space at this moment to get started. And so what I'm going to challenge each of you with is the question, if this isn't it, if something didn't work, what's the alternative? And most importantly, I don't want to hear in all of the above, right? Where do we get started? How do we get started? What to you is the opportunity in the space that you've been studying to get started? And then please briefly tell us maybe once you warm up and you show some results, what would you need to add, right? What other elements, structural elements or cultural elements or other elements you would need to add to truly make that thing work? So I just want to know a starting point. And I'm happy to go in any order because I think different presentations had different, we're closer or farther from this maybe question. So I'm happy if somebody wants to raise their hand and get us started. Please go ahead, Mark.
Drugs and money. That's what's needed. So in cardiovascular care, we need, oh, well.
I mean, why don't we just
sorry.
come to you? Maybe there are civil
I
bullets.
just thought that would get you going. Drugs and money.
Please go ahead.
That's usually a pretty good place to start. So cardiovascular care requires cardiovascular medications. We could use better medications, longer acting ones. This retention issue that Elvin, I've learned from him, this is a huge issue in cardiovascular care that's totally ignored right now. But it's a huge issue. But if there's not medicines available at the facility, we delivered hundreds of thousands of doses of blood pressure lowering medicines. That I think was key. To diagnose it and then here's a script, that's not gonna happen that routinely. And then if there's not money to reduce the financial burden of the poorest of the poor, 25% of the people in our study had no formal education at all. It's just not gonna happen. So yeah, drugs and money.
So was it the drugs or was it the ease of use in getting, obviously the drugs, I think there's a physical story to be told here, but just what I'm hearing you say is that drugs may have been somewhere, but what you did in your interventions,
Closer.
Closer
exactly.
and easy.
Yes.
And easy.
Yes.
And a one-stop shop. So actually you are changing the system. It's not just the drugs.
So we had polypills or combination therapy approved by the WHO's model list of essential medicines because MSF likes using them in humanitarian crisis or conflict settings. So the supply chain simplification is key.
Right. Wonderful. Thank you. Elvin, you're up.
So thanks. So part of this, I think, in my view, has to do with the questions we're trying to answer with science. Drugs and money are necessary, but the question, they're not always sufficient, right? Okay, given the fact that we are never gonna have silver bullets and we're never gonna have something that works and we can just call it a day, we have to ask, why are we looking for those solutions? And what kinds of questions should we be asking instead? I think some of this, in my view, and I could be wrong about this, but I think it's a little bit of a capture from sort of clinical research, right? Where you ask the question, is it A or is it B? You do the trial and tomorrow it changes practice because it's published in the New England Journal. We change practice based on that randomized trial or that set of randomized trials all the time. So in complicated situations like health systems or organizations, the question is never, does it work? It's when does it work? And under what conditions it works, right? And I think we recognize that, but we don't formalize that scientifically. So in other words, there's no such thing as total generalizability, but there is such thing as defining the boundaries of the generalizing that we can do. So an important insight might not be that leadership training is important for sort of improvements in performance when the healthcare workforce is adequately staffed, right? That might actually be a somewhat generalizable thing, but putting those conditions on it, putting those boundaries on it, is a different kind of scientific enterprise, not sort of driven entirely by quote unquote primary outcome, but instead by trying to understand the mechanisms by which things work. If we understand the mechanisms, we're in a better position to talk about the conditionalities and to turn context from everything and anything to the things that affect that mechanism specifically.
So mechanisms are important, but Jose, would you agree that that things always work under different circumstances? Because you said it's not that things don't work. I wonder if, Jose, you would disagree that sometimes things just don't work, no matter which system you apply them.
And no, that's, well, I feel like you're trying to tell me to disagree with what you
I don't want to lead you in any particular direction.
I'll disagree with them.
Yeah. Is he Canadian too? I'll say one thing, or a couple of things. When it comes back, I'll just bring it to the value-based payment models.
That's what I was referring to. You don't have to disagree with them on everything.
So when it comes to
value-based.
But when it comes to value-based payment models, in the US, we put so much time, money, we spend billions in the United States making these programs. And the intent, and it's in the law with the CMMI, which is our innovation center that created these programs, it's in the law that these programs need to save money. And so the goal was design programs that change the healthcare delivery to save money. That was the goal. But then the problem is that we had a series of models that did not address why we're spending so much money. And in my opinion, it's two reasons. Number one is prices, and then none of the programs address prices. And the second one is administrative complexity. And none of them really address administrative complexity. They all try to incentivize marginal gains at like doing a little bit of less hospitalizations or a little bit less nursing home care. And yes, we save $100 per person over the course of the year. And then we come out and we're disappointed and we spend 10 years and about $8 billion and we didn't save any money. And it was at the end of the day is if the intent was to save dollars or at least control rising healthcare costs, then we started off on the wrong foot. So it really matters what the goal is, and then you have to ensure that the programs you're implementing are actually addressing the goal.
Right, so you're actually in agreement with Elvin that knowing a little bit about the mechanism, like for example, where costs are coming from, would have been helpful in this instance. Tracey, I see you with ideas to jump in, please.
Sorry, I'm following on Mark's theme, just two things, but mine's not drugs and money. Mine is, from what I've seen, is two things, accurate and timely data, and then committed and strong leadership. And I think the best example I've seen of that recently is in Indonesia, Minister Budi. He came in, he was a banker, didn't understand about healthcare, wanted to understand where the money went. He said, if someone came into my bank and said, where's my money? And I said, I don't know. Then he said that wouldn't be acceptable, and I'm now health minister, and I say, where's the money going? And people say, we don't know. So actually, we worked with him through our partners in terms of following the money, understanding where the money goes, then improving allocation, using digitalization, and then through that strong leadership, and during his tenure as Minister of Health, he's changed the legislation. There's now a regulatory framework. So he's one of the best examples I know around sustainability, because everything changes with political cycles. But actually with really strong leadership, when you get things right, then actually being brave enough to actually change the legislation and have a reform agenda, I think is really critical.
So Tracey is on the team money, drugs, leadership, and data, right? Just 4 things. All right, Xiaohui, what are they missing?
If I can I request to show my last slides, because I forgot that, but I will not depend on, if it's possible. If it's not, it's okay. I think when I talked about the training program I introduced in the field, I think money is definitely very important. To run the RCT is very, very expensive. And I think besides the things I mentioned, I think there are some other things to be embedded in the health system. Like what I mentioned is the CME, the continual medical education, should be embedded in the system, and also the supervision, and also I think the feedback loops is very important. And the physician just mentioned that I didn't get any feedback, so I think I did pretty well. So that's why there's no, like, the effect size is very, very slow when I talked about that things in the local context. So we think about the booster, the pathway forward. I think we need to embed all these things into the structure of the health system. Thank you.
Yeah, no, thank you. That's a wonderful, actually, concluding slide in some ways, right? Because what I'm hearing from so many of you on this panel, maybe except for you, Elvin, I don't know. I'm just making sure you're awake. issue is, you started us down this direction, right? You're saying change structures. I think we identified this in the commission very strongly. The structures have to change, pre-service education. Before, this is a bit like your example, Jose. You're saying if you're trying to fix the cost problem, maybe start with where the cost drivers are, right? And if you're trying to fix the competence problem, maybe you should start with where that competence is built. And it's not built in the clinic, it's built in med school and nursing school and in pre-service education. So what are the reforms? What are the advances in those spaces that could dramatically change? And of course, that's not enough. You still need the supervision, the intrinsic motivation, the payment, and all of those things to make sure that competence stays alive and is reflected in patient care, right? So I think the idea, I'm taken by this notion of we're changing structures, but also the people inside those structures, and I consider people part of the structure, these things are interdependent. And so the idea of bringing in a single thing, whether it's a silver bullet or it's a payment model or is a sort of naive approach, I would say, from what I am hearing from all of you, right? Data alone or training alone, or maybe even one leader alone, but without the ability to understand the issues or motivate others to follow, would be insufficient to the size and the scope of this problem. And I think this conversation is just beginning. Tomorrow, we will dive into more elements of improvement, and particularly improvement at scale. I just want to emphasize that I don't think anyone in this room, and certainly the focus of this meeting, is not on pilots. Pilots are often needed, demonstrations have to be done to just show something can work anywhere. It's a feasibility assessment. But that's not where improvement should aim for. Improvement that we're interested in is at scale and meaningful to populations. So with that, please join me in thanking this incredible panel. Thank you all.